Medication-assisted treatment is a combined use of behavioral therapies and medications within a comprehensive substance use disorder treatment plan with the end goal of patients living a productive life in recovery. The goal in these programs is to decrease cravings, decrease withdrawal symptoms, block euphoria if relapse occurs in tandem with counseling services with the end goal of reducing recidivism or relapse. Let's start with a quick opioids 101. Opiates are naturally occurring in the poppy plant Papaver somniferum. This will be codeine and morphine. The semi-synthetic compounds are derived from codeine and morphine, which include hydrocodone, hydromorphone, oxycodone, oxymorphone, and heroin. The opioids are compounds that are structurally similar to opiates and act on the opioid receptors. Here we've got methadone, buprenorphine, meperidine, tramadol, to name a few. Opiates primarily affect the central nervous system, which controls the primary functions of the body. This is why the lungs and GI tract are largely affected. Intended effects include analgesia, sedation, euphoria, and unintended include respiratory depression, constipation, drowsiness. The respiratory depression is largely responsible for fatal overdosing. Tolerance can result in each subsequent dose, which can lead to life-threatening withdrawal. This same tolerance can be responsible for overdose. When a person abstains for a length of time and then reintroduces a substance into their system at the previous dose they used before, this can cause an overdose as the person no longer has the same tolerance to these drugs. A quick side-by-side. All opiates are narcotic analgesics, but not all narcotic analgesics are opiates. I won't read these lists out for you, but you can see here to the right that we have meperidine, propoxyphene, tramadol, fentanyl, along with our other MAT drugs, to name a few. Common medication utilized in MAT programs. For this discussion, I'm only going to focus on the MAT drugs specific to the treatment of opioid dependence, which are methadone, buprenorphine, and naltrexone, but I've listed here for you the medications for alcohol dependence as well. How do these work? There are three types of drugs that work at the opioid receptors. Agonist, a drug that initiates a physiological response when combined with a receptor within the central nervous system. For example, opiates are our agonists. A partial agonist, a drug that binds and activates the receptor but has limited response as compared to a full agonist. This will never actually achieve the maximum effect that the agonist achieves. Buprenorphine would fall into this category. Finally, antagonist. And that's a drug that interferes with and blocks the physiological action of another, which would be, in this case, naloxone or naltrexone would be used to completely block the action of an opiate. I've placed a pictorial of how these work. Over to the right, you see an example of the standard opioid receptor. If you think of it as a lock and key fit, methadone to the far bottom left fits the lock in the same way the opiate would for a complete binding. Morphine in the middle is like a key fitting in the hole, but not necessarily fully opening the lock. And so it generates a limited effect. And then here to the far right, we have naltrexone that completely blocks the receptor from acting with any opiates, not allowing the binding. This is how they would compare with their effects on the receptors. The replacement therapy methadone is a full agonist. Binding completely, has the most similar effect to the actual opiate and mimics its potential. The partial agonist here, buprenorphine in the middle, also a replacement therapy, mimics the opiate to a certain point, and then you can see a ceiling effect occurs and never quite hits full potential, regardless of dose. In fact, larger doses do not increase the pharmacological effect, but do increase duration of blockage and withdrawal suppression. Finally, at the bottom is naltrexone, or naloxone, and that is our blocker form of treatment, preventing any opiate effect. Let's talk about each one of these in a little more detail. Methadone is a full agonist, so binds completely with the receptor, as we spoke, blocking the high if used with other opiates. It requires special licensure by SAMHSA and the DEA because it is a controlled substance similar to hydrocodone or oxycodone. Dosing is often administered at the clinic on a daily basis due to the very high risk of overdose if administered incorrectly. Buprenorphine. Buprenorphine is a partial agonist antagonist and operates at about 40% of the activity of an opiate and then caps out there. Because it has a capped out effect, it has a lower overdose risk than methadone, which allows for weekly office visits versus daily dosing. This can really be helpful to customize a treatment plan for each patient. You can also see here it is a Schedule III controlled substance similar to Tylenol with codeine, so it does not have the same strict licensure requirements to prescribe. There are two combinations of this. One that contains naloxone. This is a typically preferred method because the naloxone, if taken orally, is metabolized out of the body as a non-active waste metabolite. If the client chose to try to crush and inject it, the naloxone prevents the buprenorphine from binding at the receptor and therefore prevents the intended effect and potential overdose. Then we have our mono product down here, which is buprenorphine only, and that's preferred in pregnant patients and individuals that are sensitive to naloxone. Finally, naltrexone, our antagonist that blocks the receptor completely, preventing any opiate from binding. This therefore diminishes the effects of opiates. Many think of this as a long-acting naloxone. It is important to note that an individual this is administered to must have undergone complete detox because if administered to an opiate-dependent client still using, it could actually precipitate withdrawal prematurely. It's often used in inpatient drug rehabilitation and for recently released criminal justice scenarios. In these scenarios, individuals might relapse after release. And as I mentioned before, while incarcerated, they experience a drop in tolerance. So this would help to prevent overdose on relapse. Next, I put together some slides on regulatory guidance. Drug testing is the technology of addiction treatment. This consensus statement from 2017 describes best drug testing practices and protocols in drug treatment programs across the country according to the American Society of Addiction Medicine. They state here, drug testing panels should be based on clients' drugs of choice, prescribed medications, and drugs commonly used in their region or peer group. They go on to say panels should be regularly updated based on local and national trends, and you should work together with your laboratory to know what those trends are. ASAM further recommends that each client's treatment plan should be customized to the client, and that plan should dictate the testing frequency. They state very clearly that patients and patient care should be patient-specific. Consensus further dictates that testing randomization is preferred over scheduled testing, and that even includes randomizing the matrix. They also point out to understand the test's detection capabilities and windows of detection in order to determine the frequency of your testing. So that means that oral fluid might only capture the last 1 to 2 days, while urine might capture 3 to 5. So understand the window your test is providing to assess frequency. Moving on to some guidance from SAMHSA, the Substance and Mental Health Services Administration, you will actually see some common themes here between agencies and associations in the field and the regulatory guidance. They state frequency of testing should be based on a patient's progress in treatment. Drug tests should be performed with sufficient frequency and randomness to assist in making informed decisions. MAT drugs should be tested for parent and metabolite, and here their suggestion minimum panel, again pointing out local substance abuse patterns. More from SAMHSA. Opiate treatment providers should confirm positive results. And here they say treatment decisions should not be based on a single test result and should be used clinically for guidance and not punitively. And that is really important because, as many of you know here that are involved with treatment, you know that immediate abstinence is not a realistic goal and that relapse can and should be expected on the road to recovery. So let's switch gears a little and look at some drug testing trends in MAT. We did a recent analysis of over 10,000 Cordant samples that were positive for methadone, and an amazing 72% were positive for some other drugs prescribed or illicit. You can see here that of that 72%, 52% were opiates positive, 33% for amphetamines, benzodiazepines 26, and you can kind of look at it as you go down. I won't list them all for you. I'll give you a couple seconds. We also looked at buprenorphine. A recent analysis of over 14,000 samples for buprenorphine positives resulted in a 50% were positive for some other drug prescribed or illicit. In the buprenorphine group, cannabinoids or THC at 34% was the most popular, amphetamines at 26%, gabapentin at 24%, and so forth. So out of over 16,000 samples tested for MAT providers, these are the most commonly ordered drug classes that we saw: opiates, amphetamines, benzodiazepines, fentanyl, oxycodone, cocaine, methylphenidate, gabapentin, marijuana, heroin, and pregabalin. All right, so let's talk about some testing considerations. Point of care. Point of care screening is an instant screening result that you can get in your clinic or in your office. It's immunoassay-based testing, but it's slightly limited by around 12 drug classes or less. Cutoffs are generally higher than confirmation testing, and they're good for illicits, but not for opioids. And I'm going to elaborate a little more on the next slides on that. The results are qualitative and drug class specific, and that means you will only see opiates as a whole class and not a specific drug like morphine. And they do not differentiate parent from metabolite. So you will not capture a quote unquote pill scrape scenario, which would be the parent drug only. A pill scrape, if you don't know, is an individual scrapes a little of their drug into the sample to cause a false positive result. So these are subject also to false positives and false negative results. Because of these two things here, the subject of false negative and positives and the differentiation of metabolite from parent is why they're good for immediate conversations in the office or clinic, but really you need to confirm the results before making any clinical decisions or change in their treatment plan. We have a case study we performed for you here, and 400 pain management urine samples were screened side by side and confirmed with the point of care cups against the LCMS testing methodologies in our laboratory. 18% of the total tests were read positive in the office but confirmed negative, and 3% were read negative and confirmed positive. But what I really want you to take away is to the right here, that in over 400 samples tested by point of care and then ran by LCMS, in multiple brands of cups, 40% of the total samples had one or more tests that actually disagreed with the initial read on the point of care cup. 40% is pretty significant when you're talking about making clinically informed decisions. So let's look at these broken down. These were point of care read in the office as positive and actually sent to the lab were negative. So we've got buprenorphine here at 0% false positive, methadone at almost 16% false positive. But I want to point out the benzodiazepines and the opiates. And you'll see here that are at 23% false positive and 22% false positive. Now, that's pretty significant when you're talking about reading results. This could be due to multiple factors. This could be cutoff differences between the cups and the lab. It could be cross-reactivity to other drugs, or even the subjective nature of reading the results on the cups themselves. False negatives. Here we've got buprenorphine at 3% false negative and methadone at 0.6%. But let's look at, again, benzodiazepines, 15%. And opiates here at 10%, and you've got oxycodone at 6%. So this is why those opioids are not great for these point of care, but illicits, they act very well. So a little more guidance specific to point of care testing per SAMHSA. POC tests are not by themselves adequate to satisfy the regulatory requirements for drug use testing services. These tests are presumptive and can cause a practitioner to make an erroneous assumption or clinical decision. Drug testing methods in the laboratory. Immunoassay screening is very similar to your point of care. It is also drug class specific. You do have a wider variety of tests than the point of care cups and more allowance there for different drug classes. The cutoffs are comparable with the point of care cups. They also do not differentiate parent from metabolite. And they're subject to false positives and false negatives as well, but I'll point out that they're not as subject to these results, false positives and negatives, to the rate that the point of care cup is, but there's still a possibility there. Which is why confirmation is always recommended. LC-MS confirmation, liquid chromatograph tandem mass spectrometer. We've got the platinum standard. There are absolutely no false positive or negative results. It is drug analyte specific. So now you're going to be looking for, say, the morphine versus the opiate class. The samples must be prepared for analysis. It's got the most extensive testing menu, allowing for a much larger allowance in drug classes. The cutoffs are very much lower than your screening tests, and that's allowing for a longer detection window. And the parent now and metabolite can be separated out and identified. And this is important because this would be the tool to capture a client that might perform a pill scrape that we talked about. Since the screening only detects the parent drug, the clinician might assume the client is compliant, but once sent to the lab, it might be discovered that there was no metabolite in the sample, so they were subverting their testing. Here's a breakdown of what a chromatograph looks like and how we can determine specific drugs within an entire class through separation and identification technology. You see here to the far left is morphine at position 1, and then 2 is oxymorphone, 3 hydromorphone, and so on. All right, so let's get to the fun part. Let's talk about some commonly asked result interpretation questions that we've actually received in our laboratories. Why is this sample negative for the metabolite in urine? High level apparent drug without metabolite present could indicate your pill scrape. So this is exactly what it's going to look like in that scenario. You've got high level of buprenorphine here at this greater than 20,000 with the lack of any metabolites present. All these scenarios I'm going to describe to you could be consistent with both, could be applied to both methadone and buprenorphine. So this is exactly what that would look like. The absence of metabolite indicates subversion, and screening without confirmation would not have caught this because it would have only picked up that parent drug. So you would not have found this in a point of care or in an immunoassay screen. Why is this sample negative when I know they took their medication? Hydration status of the client is important when trying to interpret urine testing results. So you look down here at the bottom in our validity testing, you'll see we have a dilute sample for the creatinine and the specific gravity. A dilute sample reduces the concentration of all drugs and metabolites in urine. Sometimes this is intentional and sometimes it is not. So in this example, we've diluted down all drugs within the sample to below the levels of detection. In this scenario, we would recommend you recollect a new sample or consider randomizing the matrix to an oral fluid that is not subject to dilution effects. Why are there no metabolites present in oral fluid? Oral fluid is a direct filtrate of the blood and mimics what is present in the bloodstream. Drugs are rapidly converted to metabolites and sent to waste through the liver and kidneys, so are not found in high concentrations in blood. As a result, the metabolites are not often found in the oral fluid cavity. So this is exactly what you'd be seeing. You've got some buprenorphine parent present and the lack of a metabolite there. It's not to say that you will never have metabolites, because you will sometimes, but just be cognizant that in oral fluid, it's not uncommon that they would not be present. My client is taking BUTRANS. Why isn't the sample positive? We need to understand the cutoff values of your testing. So BUTRANS is often found in much lower levels in oral fluid and urine because of its extended release formulation. This means a very small amount of drug is consistently administered over a long period of time. Therefore, lower level doses equal lower levels found in urine and oral fluid. Unlike Suboxone, it requires a lower level reporting limit specially designed for low level detection. So pay particular attention down here on the bottom of the slide where you see the EIA screen was at 5 nanograms per mil. If this person if this result was only ran for the EIA screen, it would have been a negative result. But you see below here the much lower level ran by LCMS. So this sample would have been negative as screened alone, but utilize this special lower level BUP confirmation test by LCMS detects the BUTRANS. Why is naloxone always so much lower than buprenorphine? Unlike many drugs, naloxone is excreted primarily in the feces, so is not found in high concentrations as other drugs such as buprenorphine that are primarily excreted in the urine. So lower levels of naloxone in both oral fluid and urine is common. And so this is what that's often is going to look like for you, is a higher level of buprenorphine and the lower of naloxone. Why are the levels, this is our last question for you guys. Why are the levels so high in this sample? This sample is an example of what contamination would look like. If the client has just taken their medication orally, there could be contamination of the cavity because the drug hasn't fully absorbed yet. So you want to make sure your clients wait at least an hour after oral dosing before taking an oral fluid sample, because what you see here are these high levels of buprenorphine, the high level of naloxone. This is the actual drug still in the oral cavity, and the norbuprenorphine is closer to what's actually on board from the body. So this is a typical contamination.